including humans, are known to feel pain. Empathy is a largely human quality. Humans are prone to empathy in more visual, communicative, and measurable ways than the rest of the animal kingdom. Within humans, we find the phenomena of empathy pain, in which an individual may physically feel the pain of another without physical trauma. This phenomenon was the focus of our research. It is hypothesized that empathy and pain are correlated, and that the increase in visually perceived nociceptive pain will correspond with an increase in subjective feelings of pain. Nociceptive pain occurs when a functional nervous system experience causes the perception of actual or potential physical tissue damage. Jarvis and Eckert divide nociception into 4 phases. The first phase is transduction. An unpleasant or painful stimuli is experienced within the tissues of the body. Second is transmission. The peripheral nervous system then releases a variety of neurotransmitters that will carry a pain impulse along the nerve fibers in the spinal cord and then to the brain. During this phase, opioid receptors may block the transmission of the pain. If the impulse is not stopped, it will travel the spinal thalamic route into the thalamus. In the third phase, perception, the body becomes consciously aware of the pain. The parietal lobe is responsible for sensation and perception and interprets pain and touch in the body. Once passing through the thalamus, the pain impulse will be terminated in the cerebral cortex. The fourth phase is modulation, in which our body begins to modulate the pain response in order to slow the brain's processing of that specific stimuli. Mirroring within the mind happens when we witness an event and in return activate our own emotions and sensations as if it was happening to us. Mirror touch synesthesia. Mirror neuron cells fire when animals perform a specific behavior, but also fire when they watch other animals perform the same behavior, and are activated in the prefrontal cortex.
There were 14 women and 4 men included in our experiment, and the majority of the members were from our Psychology 432 course at Martinside College. The age range was from 18 to 24 years old, and a small group of the peers where a family member were included as well. So the participants were shown 3 video clips in a 60-second compilation and asked to rate the pain of the individual in the video as well as their own pain using the NRS medical rating system after each video. These were questions asked to the participants after they watched each of the videos. After viewing video X, rate the pain of the person in the video, and after viewing video X, rate your own pain that you experienced while watching the video. After videos, utilizing a Pearson correlation matrix, our data produced a correlation coefficient of 0.46. This denotes a moderate positive correlation between visual pain and empathy pain. A moderate positive correlation implies that pain will be felt when viewing uncomfortable stimuli, but not at the same intensity as if the subject had felt the stimuli themselves. Mirroring, our subjects can place themselves in this mirroring touch synesthesia. Mirror neurons within the prefrontal cortex fire as a response to viewing an individual experience pain just as they would if the subject felt the pain themselves. Nociceptive pain is when subjects will experience nociceptive pain as a result of viewing noxious stimuli. The stimuli will be processed via the 4 stages of nociceptive pain.
Some of the sources that we used were video development, neuroimage, which were facial cues, play a key role in our perception and vicarious experience of pain in others. Bernhard and Singer, where subjects felt empathy based on their own feelings and experiences. We have experiment development and COI that provided biopsychological reference and neuron activation, and Bernhard and Singer, which was empathy typically activated in areas of the brain in relation to the stimuli at hand. Derbyshire, which discussed the phantom limb response and confirms that pain can be felt in response to viewing an injury. And Armstrong, where our emotions and sensations are activated by viewing events and we can place ourselves within the event. So for limitations and future directions, we have the lack of direct observation, which was the ability to observe patients or to deliver the questionnaire in person, which would have allowed us to make our own observations, and not having the ability to use any sort of technology to measure physical or neural responses, which was used to require the relay on our participants and self-reports. And then some errors that we had were our experiment neglected to determine a baseline for the subjects, nociceptive pain, and operated under the assumption of no pain. And for future directions, Inclusion of increased observation technology as well as improved experimental design will increase the efficiency of future studies.